Every year, millions of women take medication to end a pregnancy. Yet the specific biological mechanics of what happens inside the body often go unexplained. This lack of technical understanding creates a dangerous blind spot. Without a clear picture of the body's expected response, a patient cannot accurately distinguish between a normal recovery and a life-threatening medical emergency. To understand how this medication works, we first must look at the baseline of early pregnancy. A developing embryo requires a highly specific, chemically stabilized environment to remain attached to the uterine wall. This stability is maintained by a hormone called progesterone. It acts as a biological glue, binding to receptors on the uterine wall to keep the tissue thick, nutrient-rich, and firmly anchored. Understanding this baseline hormonal environment is the only way for a patient to identify when the body's response has shifted from a predictable reaction to a fatal complication. The medical intervention dismantles this environment through two distinct medications, taken in a precise sequence. The process begins with a chemical blockade. Mifepristone serves as a molecular shield, attaching to the body's progesterone receptors, shutting down the hormone supply. Without this hormonal glue, the structural support breaks down, and the pregnancy tissue physically detaches from the uterine lining. Once detached, the tissue must be removed from the body. This requires the second phase of the process, mechanical expulsion. This phase is triggered by misoprostol, activating prostaglandin pathways that stimulate the uterine muscles to flex and tighten in a rhythmic pattern. These contractions drastically increase internal pressure, forcing the detached tissue downward and out of the cavity. The cramping and bleeding a patient feels are the direct physiological results of this sudden hormonal drop and the intense mechanical pressure. Moderate pain and heavy bleeding are the intentional, expected markers of a successful mechanical expulsion. The critical question is identifying the exact physiological threshold where this expected process becomes a dangerous hemorrhage. In a normal recovery, the body's blood loss remains within a safely regulated limit. The bleeding eventually slows as the body stabilizes itself. A medical emergency occurs if the body fails to clot. In these cases, blood loss violently exceeds safe biological thresholds, crashing blood pressure and reducing oxygen flow to the brain. This threshold is marked by specific physiological indicators: a sudden onset of severe dizziness, blurred vision, and a physical inability to stand upright. A secondary danger threshold is systemic infection, indicated by a fever that persists for more than 24 hours after the medication is taken. Confusing these specific signs of hemorrhage and infection with standard cramping is the single greatest risk a patient faces during the procedure. While the biological mechanics are complex, the practical application happens at home, where a patient must manage their own care. Safety depends on two prerequisites: confirming the exact duration of the pregnancy and securing guidance from a qualified medical professional before starting. If the process begins to deviate from the expected path, seek immediate emergency care for excessive blood loss, severe abdominal pain, or a fever lasting over 24 hours. Identifying these specific warning signs early allows for medical interventions that effectively prevent fatal outcomes. Medication abortion is a powerful medical tool. By understanding the rigorous science behind the process, patients can replace uncertainty with life-saving protection.